Welcome, everyone. Thank you for coming. I have a crew with me here from Cahaba Medical Care. I'm Dakota Price. I'm a family medicine physician at Cahaba. And so it's going to be a panel style today. I'll introduce them here in a bit, but first I'm going to preach a little bit to you. And so, I wanted to be upfront with y'all today. My goal is my very biased goal, that is to make you fall in love with family medicine. And so hecklers from the outside. So I know it looks like maybe we got some students right here, maybe at least some students right here. Nice, okay. It's kind of geared towards students, but if you're not a student, you can always do a career change. If you're not in family medicine, that's fine. So I know most of y'all went to family medicine because you wanted to do good and you wanted to help people, and that impulse is really good. For a lot of us here, family medicine is a lot more than a career. It felt like a calling for many of us. But before we kind of talk about family medicine and how that can be a vehicle for that calling, I really want to give you an honest picture of the healthcare system you're working in today, okay? Because no one really gave me kind of this when I was going in, and I would have really appreciated it. So we're going to do one interactive thing here. This is a Slido. So pull out your phones. This is high-tech QR code technology. I don't know if you've ever seen it. And so the question is, if you were building a healthcare system from scratch, what should be included? Just like a phrase or a word. And I think as you're entering it, it should just pop up on the screen. Doctors, nice. I don't know about that one. Nurses, all right. No non-clinical admin, nice. Time, interpreters, community, money, air, social, air. Nice, housing. Equal distribution, love it. Okay. Thank you all for answering that. So let's build this together. And this is not all inclusive, but these are 4 things I was thinking of. If you're designing a healthcare system from scratch, what would you need first? So, of course, you would want it accessible to everyone, right, in your population. So geography, income, demographics, none of those should determine whether you get care. Because a system that doesn't take care of all the population is not just inefficient, it's unjust. And second, it's got to be built around prevention first. So we'd rather do diet and exercise to prevent a heart attack than have to give a stent, and then they deal with heart failure down the road and suffering and massive downstream costs that we see in that patient. And third, I think this is really important now, it has to be relationship based. We're in the era of a lot of information, Dr. Google, AI, health podcasts, social media, misinformation. So I think a continuous relationship with one physician over time is very important. And then fourth, and this is a big one, I think, it has to be affordable, not just for the wealthy. It's got to be for everyone. And the system can't really exist if it's just bankrupting the families that it's supposed to be taken care of. So does our current system meet any of these criteria? Let's look at the data, okay? All right, this is gonna be a little data heavy. I'm gonna talk about money a lot, so just hear me out for a little bit, because I do think it's important. We're in a world of finite resources, okay? So it does matter enormously how we steward and spend those resources. So as of 2024, the United States spends $5.3 trillion on healthcare annually. That's 18% of our entire GDP on healthcare. The per person cost is about $14,885. That's more than some people in my neighborhood make in a year. And I want you to keep that number in mind because we're going to kind of compare these numbers to our peer nations. And unfortunately, it's not getting any better. So by 2033, we're projected to be about 20% of our GDP. So that's 1/5 the entire American economy spent on healthcare. And we spend, this one should irk you a little bit, 5 times more admin cost, 5 times than our peer nations. So that's money that doesn't even touch the patient. Billings, prior authorizations, paperwork, all those type of things. All right, so surely with all this massive $5.3 trillion, we must have the best outcomes in the world, right? Okay, let's check. So this is us comparing to our peer nations. All right, so life expectancy. To me, this is the big, this is the big measure at the end of the day, right? Like, so how long are people living? So our peer nations are 82.5 years. We are 78.4. This is nearly a 4-year gap. So think about it, that's 4 more years with your parents, with your grandparents. This is 4 years that the system is costing the people we actually love. Maternal mortality, right? A mother dying, bringing birth of her child into this world. Our peer nations are under 5 per 100,000. We're at 17.9, which is the highest amongst our peer nations. Really sad thing. And then, yeah, we talked about that healthcare system, right? We wanted it accessible to everybody. Well, we are, our peer nations have achieved about universal coverage through different means. And we have 27.2 million uninsured Americans. That's about 8% of our population. And given recent legislative direction, that number is projected to exceed 30 million within the year. And this is just some of these things, but across nearly every major health metric, we rank last among high-income nations, okay? For once, we're not the best, I'm just telling you, last. So from a pure investment standpoint, okay, think about money again. When you put more money into something, you expect some better returns, right? That's how it works a lot of times. And I knew this was going to be bad, but this graph kind of blew my mind. So on the y-axis here, we have life expectancy. On the x-axis, we have healthcare spending per capita. All right, and this is from 1980 to 2024. And you can see our life expectancy in 1980s wasn't that different. We were a little bit under 2 years compared to our peer nations. But see, that gap is just widening and widening and widening over time to 4 years. And if you look at spending, like the graph is just getting kind of comical at this point because we are going so far on the x-axis that we're almost off the graph. And I think the craziest thing when you look at this, so you look at 2010, we've flatlined. We haven't made any changes in life expectancy despite massive increases in spending. So it just really blew my mind. So we're really throwing trillions of dollars at a system and we're not getting much back in return. To me, that's kind of a definition of a broken system. So if those slides didn't quite land for you, I'm just going to sum it up. We are the most expensive healthcare system in the history of the world, and we rank dead last among our peers. Okay, so humor me for a second. I wanted to consult the leading minds of our time, right? So I gave ChatGPT, Claude, and Gemini the same 2 questions about what is the healthcare problem and what is the solution. Just type the exact same question in all 3, okay? Let's see what these brilliant minds said. Okay, you don't have to read all this. Of course, the problem is complex, multifactorial, right? There's no surprise there. But I do want you to notice one thing. Every system had in common, independently, every single time it always pointed to primary care, okay? And the critical necessity of investing in a robust primary care infrastructure. So I'm not here to tell you we should be taking medical policy from chat, all right? I'm not. But it is worth noting, like you think about these systems, they're pulling from a large body of literature to come up with these answers, and they all landed in the same place. This is not because AI discovered something revolutionary, all right? The evidence has been here. We've known this for decades. And I'm going to take us back in history to kind of look at that. But I did think that was interesting. All right, country error doctor. So before we look at where we're going, I kind of want to look at like where we came from and how we kind of got to this situation. And most of us didn't live the country doctor era, I don't think. No. So, this was a physician. He came to your house with a leather bag. He delivered your children, treated your patient or your parents, and knew like 3 generations by name. And this is the way it was set up for most of American history. One physician handled birth, death, chronic illnesses, acute care, all those things, in a single lifelong relationship with the patient and their entire family. And then came World War II, all right? New technology, new medicines, new possibilities, which was good. It's a good thing. But we had this wave of subspecialization across America, and that started fragmenting patients' care in ways that we're kind of still reckoning with today. And thankfully, early on, the medical establishment recognized this was going to be a problem. And even by the 1960s, okay, 60 years ago, it was clear patients no longer had a single physician coordinating their care. They just had a collection of subspecialists kind of managing a piece, but not the whole person. So there actually was 3 big commissions, the Millis, the Willard, and the Folsom Report. They all had a little bit of a different agenda and a different mandate, but they all landed on the same spot, same conclusion, was that America needed the family doctor back. Does that sound familiar? Even in the 1960s, every independent body who looked seriously at the problem saw this as one of the solutions, all right? So thankfully, the reports didn't just sit there. They sparked action, and on February 8th, 1969, family medicine became the 20th recognized specialty, which is crazy to think about today, 20th. There was 19 before that. No telling how many there is now. So the specialty the country needed had arrived, but the question was whether we were going to actually invest into it. And I think this is the tragedy, is as family medicine was being born, healthcare costs were already beginning to balloon. So in 1960, we were 5% of GDP, and that was very comparable to our peers. And then by fast forward to 2000, we're at 13.3%, which is way, as we were looking at that graph, way beyond our peers. And today at 18, and we're projected to be over 20%. So 1/5 of the largest economy in the world, again, and throughout every decade, the cost explosion and the specialty, family medicine, that was designed to kind of help with the issue, was systematically kind of being undervalued, underfunded, underpopulated. And so we kind of built the answer, but I think in essence, we starved it for a long time. All right, so I'm almost done preaching. All right, so what does the current system actually look like? It's really specialist first by design. Okay, so like every 5 cents on the dollar, only 5 cents on the dollar goes to primary care. The rest, 95%, is specialists, hospitals, admin, pharma. What is this getting us right now? Less life expectancy and ranking last amongst our peers, 10 out of 10. Let me ask you, what do you call a system that waits for you to get sick, throws enormous resources at treating you, with almost nothing invested at keeping you well in the first place? Right? You don't call that a healthcare system. That's a sick care system. And that's exactly what we're dealing with, is a sick care system. That's what we built. But what if we shifted money back into primary care? And I want to be clear, I'm not saying we need to spend more. That's the last thing we need, is more money on an already bloated system. But we need to shift it back toward primary care, match our peer nations. So if we did somewhere between 10 and 15, what would that get us? Hypothetically, that would get us higher life expectancy. And every dollar spent on family medicine is said to save the system about $13 down the line. And so we're not spending money on primary care. We're avoiding spending far more on hospitalizations, ER visits, and specialist workups that didn't need to happen in the first place. We see this all the time. So prevention's cheap, all right? Crisis care is not. And I think the data backs this up. There's one big JAMA article talked about a primary care-centric model versus a specialist-driven model. It was twice the cost savings. So apply that to 5.3 trillion. That's saving us trillions and trillions of dollars. And the other countries that do this, they spend less, they live longer, they rank higher. I don't think the evidence is ambiguous. All right, I'm done with the data part, but I just felt like that was, yeah, you needed that. I needed that. But I do want to flip the script for a second, okay? And then I'm going to let them talk. Because I don't want you to leave here discouraged. I really want you to leave here inspired. Because what I need you to understand is as a family medicine physician, you are uniquely positioned to be the most powerful force for good for your patients and community. So because we care for people from womb to tomb, right? I think I made that up. We deliver their babies, manage their chronic illnesses, treat acute illnesses. We walk with them through their final days. But it goes even further than that, especially in underserved communities like CCHF. A lot of times we're the only access point for like addiction medicine, HIV care, hepatitis C, conditions that can devastate communities. But in specialists are a lot of times not even available. And we're cool as well. We perform procedures, ultrasounds, musculoskeletal injections, biopsies, stress testing, skin procedures. One way to phrase it is we didn't just choose a disease, we didn't choose an organ, we chose a person, okay? And everything that comes with that person. And when one physician can do all that in one place for one patient, I think it's a really powerful thing. Not just for them, but for our society as a whole who's dealing with a unsustainable system. So, many members, one body. In CCHF clinic settings, that one body often has to do it all. Because for your patients, there's no other options. There's no other door to knock on. You're not one choice among many. You're the only choice they have. And I just want to reiterate, because I was in medical school once and I heard these things. Family medicine is not a default specialty, okay? It's a deliberate vocation. And in underserved communities, it's a mission field. And I really think this conference, these clinics, these people in this room, there's proof that people are still willing to answer this call. And so with that, I want to introduce some real life family medicine physicians. Okay, so we're gonna change gears a little bit. I have Clay Rice here, procedures extraordinaire. I have Lauren Lincoln, she's our FMOB. She's really the coolest amongst here. And then Adam Ross, who just doing it all nowadays. I don't know what we're into, lifestyle medicine. And Adam does a lot with our faculty and procedures and addiction medicine, amongst a bunch of other things. So we are gonna get started with some questions for them. And I would love for you to think about really hard, raw, difficult questions to ask them as well, okay? Nothing's off limit here. So, question one, is this Lauren Lincoln, you gonna take this? So, let me ask the question. So, I need to go to podcast style. So when do you realize you were called into family medicine? And was there a moment you almost chose something else?
This is not very long. Hey guys. So I will say that I I probably, looking back, I would say I've always been called to family medicine, but I ran from it. I went to UAB in Birmingham for undergrad and med school. And so, it's a big tertiary care center, special, they would probably tell you that nobody hears from UAB, right? We love UAB, but they would tell you, they're promoting primary care and all the things. But I think like in all of my one-on-one interactions with attendings and faculty and specialists, it was always like, oh, you don't want to do family medicine. They work really hard and don't get paid well. And so I was like, oh yeah, that sounds bad. Like I wouldn't want to do that. I was very impressionable. I was very naive in all of the things, just not a lot of experience. Just like want to be a doctor, is ready to go. And I remember my third year of med school doing like, all the rotations, and you're like, oh, well, now I want to do this. Oh, well, I want to do this. And everything, I loved everything. And a surgeon that I worked with, we talked a lot about pathology, and I love microscopes. I love histology. And I was like, this sounds great. Like I could like work part-time, make like tons of money and like have a family, especially as a female. Everybody's always telling you that like, you can't do what you want to do. But I was like, yeah, this is great. I'm gonna be a pathologist. And like everybody that knew me that was like, okay. Because like, obviously, I don't know if you can already tell, like I'm a very extroverted person. Like I love talking to people. And I remember sitting in my first elective that they would let us do that like first rotation of fourth year at UAB with like all the new pathology interns were there. It's July. And I was like, this is gonna be great. I went to my pathology rotation. This is gonna be great. And within like 2 days, I was like, get me out of here. It was just so boring. We would pull out a slide deck and be like, okay, this is like a 64-year-old male. He had a neck mass, microscope. And like, I'm like, well, what symptoms was he having? And like, what made him finally come to the doctor? And like, well, what was his physical exam like? And like, well, what does his wife think about all of this? And like, is his insurance going to cover all, what's his treatment going to be? How are his kids doing? I was like, why is nobody else talking? And so I was like, praise the Lord. I was like, this is, I just can't do this. But I'm very thankful for all the people I spoke with along the way. Especially like family docs that I worked with that would not tell me what to do, which I appreciated, and like kind of let me work it out for myself. Because I even trained, I did a rural longitudinal family medicine rotation my third year, and I still was set to be a pathologist. And I remember calling up that attending and was like, who's the FMOB? Which now I am, which is great. But I was like, I need you to tell me what to do. And she's like, Lauren, I can't tell you what to do. Like, you really have to figure it out for yourself. But I finally was like, okay, God, like, I guess this is what I'm going to do. All that to say, not that like family medicine was like, okay, fine, I'll do it. But it was, I think, a journey for me of like fighting against what God had called me to because it was going to be hard. And that's really hard to say to other people because it makes me sound like, oh, I'm not a very good Christian. But just like that, like, sometimes we run from things that are hard. And I'm so thankful now that I get to do the work that I do because obviously God was preparing me for it all along the way. I'm just the only one that could see it. So I don't know how to wrap that up, but just like, yeah, like listen to all the advice of all the people that you're working with, because they have great, they've been there, they've been through all the things, so they have great advice, but like, don't forget to listen to the voice inside and the Spirit's leading of like what God has for you. Cause yeah.
Perfect.
Yeah. I could talk.
Yeah. Oh, awesome. Thanks, Lauren. Great. Yeah. I vividly remember, he wasn't even that cool. He's internal medicine. He was like our director. And he's like, tell me what you're going to think you see in family medicine for a day. So I wrote up on the board. He's like, I'm going to show you what I see in a day, internal medicine. He's like, I'm the Cadillac. And he looked at me and said, Dakota, you're too smart to go into family medicine. And I was a third year. So, and just to spite him, I was going to do it regardless. I love the man, but so I know some of that's out there. So the next question. So the data shows that medical students who intend to go into primary care leave the field within 5 years at a rate of over 50%. So why is that? What are we doing wrong here? Who wants to take that question? Is it Clay or Adam? Clay? Okay.
So family medicine is amazing. You get to take care of the whole person, like entire families, generations, but it's also really hard, especially with how our current healthcare system is set up. So, you have a 15-minute visit. You have a patient who comes in, they have uncontrolled diabetes, they have uncontrolled hypertension. You find out that they just were discharged from the hospital. They had a heart attack or a stroke, and now they're really depressed about that. And you have to manage all of this while also trying to keep track of quality measures, like making sure, are we up to date on our mammogram? Are we up to date on all these other things? And all this is done like in a 15-minute slot. And you do that all day long, patient after patient after patient. And that is like overwhelming.
You're supposed to tell them to go and.
Yeah, right? So
Let's be honest.
all of that to say, you have the unique ability to be your kind of patient's cheerleader and help navigate their care. They might have seen all these specialists. Do they actually need to see the specialist? A lot of times the answer is no. You can manage so much as a family medicine doctor. You have like broad training to do so much and be with the patient and kind of navigate through life crises with them. And yeah, oftentimes I run quite late in my clinic, but having like meaningful contact with patients is really, really important.
I don't run late. But that's another conversation. It's possible to not run late. That's a different.
Yeah. I mean, and this is why I bring up the system we work in, right? Because we are having, especially at CCHF clinics, we're having to do Q15. What if we got a little extra money shifted, a little bit extra reimbursement? We could do 30 minutes. You might avoid a lot of unnecessary workups, and patients be a lot more satisfied. But it's real, the system that we're in, and it is difficult, but worthy. So Adam Ross, you got a reputation for having some doozy of a patients. So could you describe the most complex patient you've managed in the last month without violating privacy? Okay. If you weren't there with your swag demeanor, seeing this guy, what specialist would have been involved in your patient care if you weren't there?
That's a good question. Yeah, we actually, most all of us at this table do a good bit of, like Dakota mentioned, we call it MAT. We treat patients for their different substance abuse issues. And those patients usually are some of the most like rewarding relationships. We actually have to see them every month for the most part. And so you get to know them really well. And so one of those guys, he's like in his 60s, and he's of course lived a really rough life, but we were just dealing in the past month or so with him. He was a opioid use disorder guy, so he had been stuck on opioids and used some more potent forms at times. He also had some trouble with meth and benzos and just like kind of polysubstance abuse. He also of course has other issues. He smokes cigarettes and has like advanced COPD and is on multiple inhalers and a bad back like everybody. And he actually had chronic hepatitis B and hepatitis C. So Dakota, helps out with this. And so we essentially find all this out and that was actually over the past year or so, but like we're able to get him on his treatment for both of those and like cure his hepatitis C. And actually Dr. Lincoln helped us get started in all this, treating hep C and doing Suboxone. And so we were able actually as a group with like Dakota and Dr. Lincoln historically has helped us a lot, like get people on, their medicines for their viral infections, clear that out, suppress their hep B. And like he was doing well. And actually this guy got to like a really good spot of, sobriety in the past number of years. And, but so we got all that cleared out recently, and like, because he was coming in so frequently, and like it's funny, like patients just get to where they really trust you and you have this relationship with them, and they'll show up to see you. Like, even if you try to get them to go see a specialist, they like will miss that appointment, and they come back, they're like, why did you miss that appointment? Like, it was so hard to work out and it took us so much effort, and they just missed it. But they show up to see you, and it's like they can get to your office somehow easily. And so he comes back, and like he's coming every month, and like of course we're just doing what you're supposed to do. And these patients who have had hepatitis C and cirrhosis, like you're supposed to screen them every 6 months for hepatocellular carcinoma. And sure enough, we picked up hepatocellular carcinoma, and we were able to get him on the treatment. He got treated for that with some crazy cool stuff down at UAB. So we love our specialist friends. We have to have our specialist friends, but like it just probably wouldn't have happened. So I don't, not that it was me or anything, but I think it's just great that he was established somewhere and he liked us and he just kept coming, and something like that got picked up. But yeah, and he's cool. He just now, you get to know each other so well. We don't talk a whole lot of medical shop when he comes in. He just like shows me his like little band that he has, and they play, like he plays guitar, and he shows me new videos of his new songs every time. So,
Could I add a little bit to that? So primary prevention is when we are trying to prevent something from happen. We have, screenings and such, and family medicine is all about trying to prevent bad things before they happen or catch things at a very early stage. Like we do mammograms for like breast cancer screening and stuff. And it's like so rewarding, like when you catch something in an early stage where, all we have to do is like a lumpectomy and maybe some radiation. Like we don't have to do chemo. We don't have to do like a radical mastectomy. Like it is like so rewarding to be able to help kind of stave something off before it becomes really advanced. And that's something that is unique to primary care.
So that'd have been what? ID, addiction medicine, pulmonology, probably hepatology. You have any cardiac stuff going on? Can we throw a cardiologist? Yeah, so 5 specialists, and who knows if he even had insurance. And that's powerful when you think about that and when you can do that for a patient. So within family medicine, you can do, some of us kind of, I would say almost kind of subspecialize, like an addiction or peds or OB. So maybe Dr. Lincoln here, what do you think, like subspecializing, let's say as an FMOB, what do you feel like you can do that a pure subspecialist, like maybe an OBGYN, can't?
So I'll come back to your question of my answers on the different. Well, no, just one thing that I feel like I finally learned. I didn't know this, I think, until I was a resident. I didn't really, because I feel like as a student, you have very minimal exposure to primary care in like the real world, depending on how you rotate. But like, once I was in residency, I get to work with all my lovely attendings, and I started to notice that, like, I was like, everybody has like their thing, right? So even though we've all trained to be like full spectrum family medicine, like we do all the things, everybody kind of has like the thing that they love. So for me, I always joked that if my practice could be like 50% OB and 50% addiction medicine with Hep C treatment, it's like super weird, right? I'd be very happy. That is now my practice, and it's wonderful. But no, so like you can, but I also still, just like Adam was saying, I have all these people that come to me for their Suboxone, but like I treat their diabetes, I treat their hypertension. I had a diabetic that came in on Tuesday that had a cellulitis on his arm, which I IND'd, and a callus on his foot that I had to unroof to make sure he didn't have a wound. And like we did that, and I just said, hey, I need you to hang on a second. I'm gonna see all these other people, and then I'm gonna come back and do all your procedures, and then we're gonna get out of here. And he was like, yeah, I'll just sit here and watch TikTok. Okay. But anyway, I know that's a tangent from what you asked, but I think because we are able to do some of the harder things like the addiction medicine, prenatal care, we don't have to turn people away. And so they are connecting to us sometimes because of that like specialty thing that they need. And then we're getting to catch all the other things as well. So like, I mean, a lot of my patients, like if we didn't prescribe Suboxone, which 10 years ago was this whole big like, oh, you don't want to do that because then you'll get, it's all this and now like we all do it. And they've done away with the X waiver and like anybody with the DEA can prescribe Suboxone. You know, like it's changed so much just even in the past 10 years, right? You know, like if we didn't do that, if we didn't practice full spectrum, like we would not have access to all these people who are like the sickest of the sick and like really need us. And then too, with doing like prenatal care, you know, there's so many young people who don't go to the doctor. And then like, you know, there's, you know, pediatrics is wonderful. We love our pediatricians. We have lots of them close by. We work with them a lot. But like being able to, and I think like you see this too a lot with like doing prenatal care and seeing kids of just like, we do get to take care of the whole family. And I've got a patient right now who's, she's 24. She's about to have her 4th kid. So that's a whole nother conversation, but she's on methadone. But I started seeing her, she was 16. Her mom is my patient. I prescribe Suboxone for her mom, and I take care of her. I don't take care of her much because she's been hard to tie down, but I've delivered all of her kids, and she actually told me she was praying before she told her mom, and I said, you better tell her because when I see her next week, it's going to be really hard not to tell her. But no, like you really do get to care for the whole family. And then like, because you know all the things, you can kind of personalize the care a bit more. Like when I see her mom, I can be like, hey, how are you? Like, how's your anxiety? Because it's bad. Because she ends up with custody of these kids when like, you know, we end up in jail and a mess and all that stuff. But the good news, they're doing really well. She's actually getting custody of our kids back, which is great. So I always say when you get people into addiction, I don't know if I'm answering your question, but when you get people back into like addiction medicine, it's like you play a country song backwards. Like they get their dog back, they get their car back, they get their kids back, they get their wife back, you know, all that kind of stuff. But I would say that's like some of the most rewarding things to do is just to watch people like have a life that's like not so hard. And that to me is really, really rewarding. That's where I think I find a lot of joy and where we find a lot of gratitude with our patients. So did I answer your question?
That was beautiful.
Okay.
I add on a little bit there too.
Yeah.
So yeah, we have the privilege of having like longitudinal care with these patients. Like we follow them throughout their lives. You know, we're, taking care of someone prenatally. You know, Lauren delivers them and then become the primary care doctor for the baby as well. And so it becomes like this generational thing. And then, by the way, my mom like hasn't seen a doctor in 10 years. She really needs someone. And I really like you. I trust you. Like, I want her to see you. There's like nothing more like rewarding than like hearing that. And even, you were asking about what do we do that specialists can't do? Not that they can't do it, but it would be harder to do is like kind of coordinating care, or you have someone with type 2 diabetes, or suffers from substance use, and you get them on something that's safer or get their diseases controlled so that way they can safely become pregnant and like maintain that pregnancy. And then like you continue to take care of them and their child afterwards. And that's just something that's really, really beautiful.
One interesting epiphany I've had, I do a decent amount of HIV care. And we have the 1917 clinic near us, which is, the oldest like kind of HIV clinic with all the kind of the subspecialties there and everything in America. And it's almost like they kind of try to bring in all these specialists to care for this one patient. And then I have them come to me. I'm just like, I can just do all this for you, and, it's simple stuff like MAT and HIV and Hep C, like these things that all kind of go together.
Just kind of like overlap.
Yeah, they overlap. And if they're at the specialist, they're going to have to go see another one. And yeah, so that's just been a very interesting epiphany that I've had recently caring for these people. So let's go to the heart. maybe get some tears up here. So the 1 Corinthians 12 metaphor says every member of the body is indispensable, right? That the parts that seem weaker are actually necessary. So do you ever feel like the weaker part? Like family medicine is undervalued, overlooked, underpaid? And do you ever resent it? I just made that one off the spot.
I think your question kind of answers itself. Yes, I would say in general, the perception of family medicine is not great. We are kind of looked down on often in medicine, I think, as just like the simple family medicine doc who is like a referral center, who just refers off to the specialists. And that doesn't have to be family medicine. So your question was, do we ever feel like kind of looked down on?
I was hoping you'd shed a tear.
Shed a tear? Yeah.
Give that to Lauren. She'll shed it.
Oh, do I ever resent it? It's like frustrating, but I think it can also be kind of something as like a motivational, like encouragement to like kind of buck that stereotype of being like, no, like I'm going to be a really good doctor. I'm going to really take care of patients well. And I'm not just going to refer off to specialists for, oh, you need your toenails trimmed. I'm going to refer you off to a podiatrist when that's something I can do,
Yeah, I think I think I would have said I would have resented it back when I was still like becoming a family doctor. But I feel like now something happens. I turned 40 this year, y'all. Something happens when you hit 40. You just don't care anymore. What people think. It's such a lovely release for me. Anyway. But yeah, I think that actually one of my mentors, she said that somebody said to her in medical school that she was going to go into family medicine. And I think it was a GI doc that said to her, that's good because they need the best of the best. And I'm so thankful she shared that with me because she's like one of the smartest people I know. And I think I have so many thoughts. But I think that family medicine does get a bad rap sometimes. And I think it's because a lot of times it's done poorly. And not to be like, oh, we're so great. But I feel like at Cahaba, we have we've grown exponentially over the past 10 years. And I think when we first kind of came into the communities that we were in, people were skeptical. And they were like, okay, you do OB? Are you sure? You know what you're doing? Oh, you prescribe Suboxone? Okay. Are you sure? And so it's just a lot of, and then we started an inpatient service and we have all these, oh, it's a Cahaba patient, it's like they're all really sick. And, but I think we all we come to work every day, just well, I'm prepared to, do my work excellently as to the Lord. And we just show up and we do our work and we take care of our patients. And I think when you do that for a long time, consistently, that people start to see that we're not just talk, we're actually doing the work. And of course, there's still plenty of people that are well, I don't want to do that. And that's fine. Please go do something else, But I think that the community starts to respond to where, I don't do inpatient, but these guys do. They'll call y'all because they know that you're going to take care of somebody, right? I could be wrong. But all the ER docs, they know all the Cahaba docs and they know that we're going to take good care of these patients. So I don't know if you have other thoughts.
Yeah, just, and this will answer just we're running out of time. But the other part of that question, Dakota, and kind of the next is what brings you back? What keeps you in the game per se? What's helping with burnout? And I have a good patient story that illustrates that, but also it's these people, and it's at these CCHF clinics, it's really amazing to work with people who are on mission together and like-minded and,
same things as you.
Yeah. And it's man, I don't know if I could do it without that and our community as we work together and try to just address these huge health disparities in central West Alabama. So yeah, that's huge. Community, as a lot of people have talked about at this conference so far, and just like super quick patient story, the patients, like we've already started to say, like they really keep bringing you back, and in a lot of ways, I mean, they can be really hard sometimes and make you want to burn out. But like, I took care of a husband and a wife, like ever since we moved to Birmingham. So it's been like 7 or 8 years, and really sweet African-American couple that were kind of pillars in their community. And unfortunately, the wife, she like smoked. They were in their 60s or so. And it was like a year or so ago, I knew something was wrong. And I figured, she had a cancer somewhere and was just looking like crazy. And like, another good part, good quality of a family doctor is knowing when you do need help. And I was pulling out all the stops, imaging and having other people see her and trying to figure out. And sure enough, ultimately, like she had a really bad lung cancer that just finally appeared. And it was, wrapped around her aorta. It was in a really bad spot. And so super sad. And, she died pretty quick. And I just remember after the funeral, her husband, who I also saw, was like, and they're just so sweet. And his daughter called up and was like, we really need to bring, Chico in, like he's losing weight now. And I was just like, I had this like dread in my stomach. I was like, oh my gosh, he's dying or something, and they're still going to be mad at me because I couldn't stop their mom from dying. And, just like, you're like, I don't know. But of course they get there and like, they're in the room. It's the daughter and Chico, whose wife had just died. And they were like so relieved. It was the opposite. They were like so relieved to be there seeing me somehow. And, they just, were like, okay, he just like needed something. Of course, it was grief. He was losing weight because of that, but also he was sick and he's got other medical issues, and he just needed somebody to be there. And like his trusted, like his pastor too, it's kind of similar, is like somebody to help him figure out how to navigate the next few months and get back on track and be there for his kids and his grandkids who were still there. So it just was like a good moment. It's like, okay, it's like, I don't need to be their savior. It's like we're kind of like, the relationship is almost sacred. It's like, it is this like relational thing, and it's so important. So yeah, that just like, that really does. And it takes years to get that, of being a physician and being out of residency and doing it for a while, but it really is amazing. Keeps you coming back. So.
That, and even touching a little bit more what keeps you in medicine and how to avoid burnout, is just family medicine is so varied that you see a wide variety of things. I think I would be so bored if I were a GI doc and only saw, the same 3 complaints all day. In a single day, I might see a newborn baby. I might see someone I'm doing an ultrasound guided joint injection in. I might see someone with HIV. I might see, some prenatal care. You just see a wide variety of things. And even within family medicine, you can kind of tailor your practice. So like, I really like to do procedures. And so I'm cutting off skin cancers and injecting things and having a lot of fun. And, I also really love prenatal care. I get to do that. I also am involved with the residency, so I do some precepting. So kind of like doing a variety of things, I think really helps keep you from burning out.
Thanks. Great. I was going to say more, but I think I want to hear from y'all instead. Leave some time for questions. Nice. See, it was in my head. So yeah, and I was going to end with, that's right, I had something here. Just kind of nope. Just kind of a challenge for y'all, especially students. Just to kind of think about these 3 questions as you leave here today, and then we'll move into our question time. But so who is the patient in your community that no one else will see? Okay, see if you can see that face or that person. And what would it cost you to be their doctor? Like, I think legit weighing the cost. But I think the bigger question is, what would it cost them if you weren't? I didn't make up those stats. Just get $100 trillion. Okay. So any questions in the room? Yep. Here, tell it to me and I'll repeat it for the recording.
I think I have a question about the educational part of this, because I think something that's been on my mind a lot is AI and care, and like kind of like the purported like claim that people will say like, oh, imagine like we have an AI family medicine doctor, every single person, like you won't need her. And I don't believe it, but then I don't know really how to respond, because like we rarely like they have some AI that like knows how to react to the situation, and like obviously on the relational aspect, I would say like it's the human aspect of it, but
Yeah.
see, like, have you guys thought about that?
Man, what a loaded question. I mean, yeah, I mean, we use AI, of course, we use it a lot. I think it's helpful. Oh yeah, so it's pretty much like this relational aspect. Can we talk about that? You know, theoretically, AI could be everyone's doctor, could build it out and be empathetic and all those things. I mean, I just, you know, if we view everything from a world lens, I think it gets confusing. We can't explain it all, but I know what God designed us for, you know, and God designed us for relationship with one another. And when we're not in that, we're sick. And like biochemically, like oxytocin, the snuggle hormone, when you're going through stress, when you're hurting, you need a hug. You need somebody, and it actually has shown to prevent heart attacks and disease. And, you know, so it's not even just what we know and read is truth, but biochemically. And so I think that would be inferior in many ways.
Like AI, I feel like AI is, I mean, we use AI, like open evidence. We love open evidence. But like open evidence is good for like one question that's like, you can ask a very specific question, but like, it doesn't know to be like, oh, but do they smoke? Or, but do that, you know, but you know that they have this, and this, you know, other things. And I just feel like people are so complex. And yeah, AI is very smart, but I don't know.
Yeah.
I'm not worried. Yeah, I don't think we're going anywhere.
Yeah. And we think with our, not the frontal cortex, I mean, our emotions drive us, right? We don't logically make decisions. Our emotions drive us. And so they're not going to logically make an AI decision. Anyways, any other questions out there? Yep. Hey.
I was trying to formulate a question to state something, so I don't have a question.
She's also an awesome family medicine doctor over here.
Because I was listening to your talk and think about as a student how I would be thinking. Right now, everybody's like work-life balance and how am I going to make this work? And maybe I don't want to go into medicine, or certainly not family medicine, because I'm going to work too hard. And I've also just lived over that 40 age, and I want to tell you something. Life is hard. And I went to my coffee shop once, and the person there, I was like, you're not going to see me for a little bit, because, I mean, I just need a break. And in my mind, I'm like, from what? You're serving coffee? So what you feel or what you worry is probably more about you and the world we live in than it is about what you do. So life's going to be hard. You're going to be overwhelmed. You're going to be burned out. You're going to be anxious. And if you're not, praise the Lord, but you're going to reach that point. I mean, I wasn't for many decades, and throw a few things in there. So do you want to be anxious and burned out doing something that matters? Or do you want to be anxious and burned out serving coffee? Nothing against it. So that state you're worried about, you can't protect against that. It's coming for you. So what do you want to do? What gets you excited? And hopefully it's family medicine.
And I love my job, honestly. I'm so thankful for what I get to do. Like, I sometimes pinch myself. Like, I get to do this every day.
Can I talk about money for a second? Or not? You don't want
Well, there was another question. Let's get to the other question. Or maybe you had you wanted to preach as well?
Quick question on that topic, but was wondering if, you guys mentioned that seeing highly complex patients, very short time. How do you guys go about navigating, recognizing, our question is to meet medical needs first, and also recognizing the spiritual need and
Oh. Yeah, so in that Q15-minute slot, how do you care for your business?
We do like some group
care for the patient, not just physically, but mentally and spiritually.
Yeah, you get creative. Like we do some group substance abuse, like MAT visits, which is awesome. And like these guys stay together for a long time. And like me or Dr. Lincoln will be in there as the physician, and we have one of our behavioral health ladies. And like, you know, you have tons of time to talk in those settings, which is great, but you have to get creative.
I also think you kind of learn when the physical is more important and when the spiritual is more important, because there's plenty of patients that like, you know, we say like, oh, I have all Q, you know, I might see 25 patients a day, Q 15 minutes, but like, you know, 3 of them are like, yeah, my blood pressure's fine. I just need a refill. I'm like, thanks. I love you. I'll see you next time. You know, and then like I'm given that time, but they know that when they're not okay, that like I'm going to give them that time. And that if I'm running late, it's because I was spending time with somebody else. I always say like, you don't want to be the one that I'm on time for. Cause like that means you're struggling. And like, because you build these relationships, like you can walk in a room and be like, are you okay? Like, I'm going to increase your lisinopril. What do we need to talk about? You know, and like, what do we need to talk about? And we even have, this is like super old school, but we have these paper intake forms, which I use. I don't know if everybody else uses. I'm like the only one that uses them. Yeah. And it says on there, you know, it's like, what do you need? And there's like a list that they can check off. And it's like, oh, I was recently at the hospital. I recently went to the ER. I need meds refilled. I need results. I would appreciate prayer today is one of the ones on there. And so like people will just straight up check that. And so even if like the whole visit, like I don't get to like, hey, how's your spiritual walk, whatever. At the end, I can be like, hey, can I pray for you before we leave? And just like, I mean, like 15 seconds, 30 seconds, you know, it's such a small part, but like the tears that fall every single time, you know, it's just like, just being able to connect, and then just, they know that like you care about them. And so, yeah, we can like do all the things. And then also, yeah, I know we're running out of time.
Yeah. Yeah. I mean, it's never go work for, I mean, like shift work sounds great, to go work in an urgent care and just, but like if you really want to make a long-term difference, you need that longitudinal aspect, because 3 minutes over 3 years, you know, adds up. But that's a great question. Part of money.
Not like I love money. That's bad, right? No, I just want to talk about money for a second. So, you'll be fine. Okay. So like, don't worry about the money. It's every doctor makes plenty of money. We work for a nonprofit. We all have salaries. Like we all have benefits. We all have health insurance. Like our kids are fine. Like it's fine. I have retirement savings. I think if you've got to learn how to manage your money. Okay. And now I'm realizing maybe next year I need to talk about this, but like from the day you start getting paid in residency, like you've got to live within your means. And just because you make a lot of money, it doesn't mean that you should spend it all. I had a lot of debt. I'm totally debt free. Our house is totally paid for. We go on vacation 3 or 4 times a year. I've got 2 kids, and like we're doing all the things, and I'm not worried about money in the slightest. Okay. So like, I'm not saying, yeah. If you're worried about money, learn how to manage it now. And then no matter what you get, and I work 2 days a week or part-time. So I probably make less than all these guys. Maybe, I don't know. Y'all work more than me. Yeah, hopefully. I don't know. We'll talk about that later. Don't be afraid to ask. Don't be afraid to ask for a raise. But yeah, don't worry about money. Don't worry about people saying you're going to work too much and not make any money. You'll be okay. God will provide. So it's all good.
Also,
Yeah.
while on the topic real quick, especially primary care in under-resourced settings, there are loan repayment programs like the NHSC loan repayment program, which helps make it possible. And even programs like as a medical student, you can get into it and they will like help like pay off your loans early, which is great.
Cool. Well, if y'all want to talk more, we'd love to hang out. We have a bunch of student undergrad and medical student rotations. There's other awesome clinics here. Audrey's from Christ Community. And so anyways, I think that made the difference for me, was going and rotating and experience those CCHF clinics with a doctor doing that. That changed my life. And so, all right, please fill out the survey. Another high-tech QR code up there.
Just give our presenters a round of applause.